I think we should start because we have so much to cover in this session. So we can start, and then they can join, those who didn't join yet. Do you know what are the total number of fellows they're going to be joining this session?
It's depend يعني different from Saturday to Saturday.
Okay. But here I see how many now? 6.
14 the practice.
So for 14? Okay, good. Well, it's good actually when we have a small number, we can make it more as a discussion more than just a regular lecture. So I think the benefit will be even higher for you. So I'm going to share and we're going to start. So I have been told that to cover with you how to assess aortic stenosis, mitral stenosis, mitral regurg, and aortic regurg. So this is going to be a long session, and I will try to cover as much as we can in this session. Like I'm not going to go very deep in the discussion, but I will try to cover as much as we can. And I think the thing that we're going to cover here is going to help you for both in your clinical practice as well as in your exam, cardiology exam. Before we start, we're going to go through some math formulas and some physics theory that will be helping us a lot when we assess the valvular heart disease. The first things, which is simple, I know most of you know this, but just to remind you how to calculate the area of a circle. So if you remember, to calculate the area of the circle, you need to measure the diameter. Then from the diameter, you divide it by 2, and you calculate the radius. And from the radius, you can square it and then multiply it by pi. Pi, it's 3.14. And then from that, you can get the area of the circle. So it's very important to know how to calculate that. This is an example. Like, for example, if you have a radius of 3 circle, you square it, 9, and then you multiply by 3.14, and you get the area. You can also get the circumference. The circumference, you get it by multiplying the diameter by the pi. And from that, you can get the circumference of the circle. The other also formula that you really need to know, and this is going to help you a lot, which is how to calculate the surface area of a curved, of a hemisphere. So this is a hemisphere. It's a 3D shape. The hemisphere, half a sphere, has a flat surface and it has curved surface. So it's very important to know how to calculate the curved surface area of this hemisphere. So to calculate the surface, you need to multiply the radius. The radius, you can measure it like this or measure it like this. So you calculate the radius, you square the radius, and then you multiply it by 2, and then multiply it by pi. And from that, you can calculate the surface of the curved hemisphere. The other thing that you need to know, it's how to calculate the slope of a line. So any line, you can calculate the slope by knowing 2 points in this line. For example, here we have this dot, 3x, 5y, and here we have 9x, 7y. And then you can, if you want to calculate the slope of this line, you subtract y2 minus y1 divided by x2 minus x1. And from that, you calculate the slope. And this is very important later on. You will see that it is important to know. The other also concept, it's continuity equation. This is from fluid dynamic and mechanic, that the flow across one area in a closed loop, a flow across one area, it's equal to another area, to the flow to area number 2. To compensate for the difference in the area, you will see that the velocity of the flow will increase in the A2. So in the A1, the velocity will be lower than the velocity in A2 to compensate for the flow. So at the end, the flow here will be equaling the flow here. And this is also important later on. One of other concept also that you need to know, it's the PISA. PISA is the proximal isovelocity surface area. What is PISA? PISA, it's basically, we are saying that in the hemodynamics, this is basic physics. In hemodynamic, when the fluid approaching an orifice, finite orifice, the flow, it will start to increase in velocity. And it will start to form like a hemisphere on this orifice. So you will see that here, I need you to imagine this is as a 3D shape, not as a 2D shape, as a 3D shape. So here you will see that the surface of this hemisphere, it will have the same velocity across. Like the velocity here, it will be equal to the velocity here. And then when you go nearby the orifice, the velocity will increase, but it's still, you're still having this hemisphere. So the velocity here, it will be equal across this surface and so forth until you reach to the orifice. And we can use the continuity equation here also to calculate the flow. So we can say basically that the flow across this surface, this hemisphere, it's equal to the flow across this orifice. And from that, we can later on, I will show you how to calculate the orifice area based on knowing the velocity and the flow here in this hemisphere. The last, I think, equation that you need to know is Bernoulli equation. There is two parts Bernoulli equation. There is the modified one, and there is the simplified one. Most of the time, we use the simplified one, which is we square the velocity to calculate the pressure gradient. However, sometimes, in some cases, and we'll talk about this later, that you will have a high velocity. Like, for example, you want to measure the pressure gradient in point P. So in point B, if you want to calculate the pressure gradient, you need to square the velocity, V2, and then multiply it by 4. However, if you have a high velocity in point A, that will affect your pressure gradient here. So if you want to calculate the pressure gradient in B, you need to subtract the velocity of the V1. So basically, you will say you will square velocity number 2, and then you subtract it from the square of velocity number 1. And then you will multiply it by 4 to get the pressure gradient. And this is important, and we'll talk about this later. Okay, so now we can start our session. So we'll start with the aortic stenosis. Later on, we'll go through mitral stenosis, and then aortic, mitral regurg, and then aortic regurg. Causes of the aortic stenosis. So the most common cause in developed country is calcification and degeneration, especially in elderly. But we have other causes like rheumatic heart disease and bicuspid. Especially here in our country, rheumatic heart disease, we see it not uncommon to see here in our country. So to assess the aortic valve, usually we always start by looking to the valve itself. So if the valve is completely normal, like this valve here in the right side, and it's opening well, so you don't need to go any further steps. You can stop and you can say that this is normal aortic valve. However, if the patient has a restricted aortic valve or calcified aortic valve, then you have to go through the steps to assess the severity of the aortic stenosis. The first steps is to assess the velocity and the gradient of the aortic valve. And to assess the velocity and the gradient, you need to measure the continuous wave. You use the continuous wave Doppler to measure the velocity of the blood across the aortic valve. You can do that from 5-chamber view or 3-chamber view or right parasternal view. You try to find the maximum velocity that you can get, and you can use that as the velocity and gradient. So basically, once you measure the gradient, you're gonna trace the curve, and then from the curve, you can get both. You can get the maximum velocity, you can get the mean pressure gradient, you're gonna get maximum pressure gradient, so you're gonna get all this information. Also, you're gonna get the aortic valve VTI, which is important later on. So you can get all this information. But it's very important to remember that your echo beam should be parallel to the flow of the blood. So if it's not parallel to the flow of the blood, you will have an underestimated velocity. We always say it's about like 20%. If it's 20% off the axis of the blood flow, then you will have a significant underestimation for the velocity of the aortic valve. So once you assess the velocity and the gradient, you will have either high gradient aortic stenosis with velocity 4 meter per second, or mean pressure gradient with the mean pressure gradient more than 40, or low gradient aortic stenosis with usually velocity less than 4. We define it as velocity less than 4 and mean pressure gradient less than 40. So if the patient has a high gradient aortic stenosis, you can say that this is if the patient has high gradient, you can say this is most likely a severe aortic stenosis. However, it's very important to exclude high flow status like anemia, hyperthyroidism, aortic valve stenosis. Make sure that you don't have a pressure recovery phenomenon in this patient. And we'll talk about this later, how to know if this patient has a pressure recovery or not. So these are very important to exclude before you say that this patient has a severe aortic stenosis. Also, you can do a couple of other parameters. You can measure other parameters to help you support your diagnosis. You can calculate the aortic valve area by continuity equation, and also you can calculate dimensionless index. The good thing about these two parameters, it's not flow dependent. So even if you are off axis of the velocity, it will be okay because you will be off axis both the LVOT and the aortic valve. So at the end, the ratio will be also still significant. So this is why this is very important to calculate for this patient to support your diagnosis. And we at the threshold here written for you that less than 1 centimeter is considered severe aortic stenosis, and for dimensionless index or velocity ratio less than 0.25 is considered as significant. So to calculate the aortic valve area, we use the continuity equation that we discussed in the prior slide. That, as we said, that the flow here in the LVOT will be equaling to the flow in the aortic valve. So, and using this equation, we can say the area here in the LVOT multiplied by velocity. Velocity, what do we mean by velocity? It can include both. It can include the maximum velocity or the VTI, which is the velocity time integral. And equal the aortic valve area multiplied by the velocity here also. We prefer to use the VTI and not to use the maximum velocity because it's more reliable and I think more accurate. So the guideline now recommend to use the VTI, not to use the maximum velocity. And so basically you will measure the LVOT from edge to edge, try to measure it within 1 centimeter from the aortic valve. And it's very important that when you measure this, you measure it in the mid-systole. So the maximum size, you try to get the maximum size of LVOT. And from the diameter, as you remember, you calculate the area, which is you divide it by 2, you get the radius, and then you square it and multiply by pi. And then you multiply it by the LVOT VTI. So as we said, the LVOT VTI, you can get this by pulse wave from 5-chamber view or 3-chamber view. And you trace it and you get the VTI of the LVOT and you divide it by the aortic valve area VTI, which is also you trace it from the aortic valve VTI. You need to try to measure from all the windows and try to get the highest VTI that you can get. This is just a quick example. So like, for example, this patient, if we want to calculate it together, just to do some practice, let's say we measure the diameter here and we get the LVOT diameter 2.45. So what I will say, 2.45, and then I will say divided by 2. I will get here the radius, and then I will multiply it by the same 1.225. And then I will multiply it by pi, 3.14. From this, I will get the area of the LVOT. And then I will multiply the area of the LVOT with the LVOT VTI after we trace it. So I will say multiply by, let's say 19 here. Then I will get the stroke volume. So this is stroke volume across the LVOT. And then I will divide it by the aortic valve VTI. So here the aortic valve VTI is 134. So we divide it by 134. And then we get 0.666, which is considered as severe aortic stenosis. So this is how basically to calculate the aortic valve area. The other point that we talked about, it's the pressure recovery. So the pressure recovery phenomena, to understand this, you have to understand the law of conservation of energy. This is a basic law in physics, which state that energy usually cannot be destroyed, but it can be changed from one state to another state. So let's take the heart. So the heart, the LV, will start to generate potential energy, static energy, pressure in the blood. The part of this pressure will be converted into kinetic energy, which what will move the blood across the aortic valve. And once the blood across the aortic valve, the blood will start to decelerate. So part of this kinetic energy gonna be converted to either to a pressure, like static energy, or into heat. So in the patient with the normal aorta or large aorta, usually most of this, there will be a lot of turbulence. So most of this velocity will be, the velocity loss energy will change into heat. So the pressure will stay the same, like in the aortic valve, across the aortic valve and across the ascending aorta. However, in the patient with the small aorta, and we define small aorta to the diameter 3 centimeter or less, they will start to have a pressure recovery, which means that part of when there is a deceleration of the blood, part of this kinetic energy, it will start to become potential energy, static energy, pressure. So that will increase the pressure, and that's actually good. It's not bad. That's good, because if you think about this, the complication, all the symptoms that occurred because the severe aortic stenosis usually occurred because there is a low pressure. But here we will have a high increase in the pressure in the ascending aorta, and this is what the brain and the other organ are going to face. So that will be good actually for the body to have a pressure recovery. But for those who doesn't have a pressure recovery, those the patient who are going to develop symptoms. So how you expect that the patient have pressure recovery based on the aortic diameter? So if the ascending aortic diameter it's 3 centimeter or less, then you can say that maybe this patient has a pressure recovery. And the pressure gradient that we see across the aortic valve, it's an overestimation for the real pressure gradient in the ascending aorta. And you have two ways actually to know if the patient has a significant pressure gradient or not. You can use this formula, which is basically you will see the velocity of the blood across the aortic valve. You're going to square it, multiply it by 4, then multiply it by 2, and multiply it by the aortic valve area divided by the ascending aortic area, and then you multiply it by 1 minus aortic valve area divided by the ascending aortic valve area. That is one way, and that will estimate for you the pressure recovery. And once you estimate the pressure recovery, you can subtract that from the pressure, the total pressure gradient, and then you're going to get the net pressure gradient, which is the pressure in the ascending aorta, which was important for us. The other way is to do energy loss coefficient, which is a simple way. I think, and this most people they will not use this in clinical practice. Most people they will use this in the patient with a small aorta. So it's very simple. You just multiply the aortic valve area, multiply by the ascending aortic area, which you're going to use the same method to calculate the area of the ascending aorta, and then multiply it here by the aortic valve area, and then you divide it by the aortic valve, ascending aorta area minus the aortic valve area, and then you will divide it by the body surface area. So this is the simple way. I think this is the one that maybe you can use in the real practice. And if you get 0.55 centimeters square, then you will say, or less, then you will say that the patient has real severe aortic stenosis. So these patients, the one that has a real severe aortic stenosis. So let's say that the patient has low gradient, like we saw at the beginning, that the patient has calcification in the aortic valve, and you checked the aortic gradient, and you find that the patient has low gradient. The second step after you find that the patient has low gradient, you have also to calculate the aortic valve area. If the aortic valve area more than 1 centimeter square, then you can say that this patient has a moderate aortic stenosis, and then you can stop here. But if the patient has a low aortic valve area, then you have to go to step 3, which is try to exclude any measurements error. And this is, I think, very, very important to know. One of the biggest source for the measurement error is the LVOT diameter. Yeah, by far. The reason behind that, there is a significant variability between the reader, reach up to 8% in the measurement of the LVOT. This is one point. The other point also that usually that, as you know, that when we calculate the area of the LVOT, we square it. We square the radius. So you are squaring the error. So if you made any measurement error, you're going to square the error. So it will be significantly influence your estimation for the aortic valve. And most of the time, we'll see those who are going to be underestimating the LVOT diameter, and that will give you a small and underestimated aortic valve area. So it's very important that you do, you have to check the LVOT VTI. We always say check the LVOT diameter from the parasternal. It's very important to do zoom view, in the zoom view, and it's inner to inner edge, and it should be mid-systole because this will be the biggest diameter for the LVOT, and it should be parallel to the aorta itself. And it should be within like not more than 1 centimeter, within centimeter from the aortic valve. The other point, and this is very important, and I always see this mistake by echo technicians. What they do, if they have a significant calcification, they will measure the LVOT. I think you see my mouse here. So they will, what they will do, they measure the LVOT diameter from here all the way to here. So they will not exclude the calcification. And this is wrong. You should exclude the calcification. So you have two ways to exclude calcification. Either to measure the diameter from here all the way to here, because you will say that this is, I can see that this is the aorta, the leaflet, the anterior leaflet. So the LVOT actually, it's all the way to here. Or if you are the one who's doing the acquiring the images, basically just try to tilt the images. If you tilt the images, you will be able to exclude this calcification, because we always try to exclude this calcification, because this calcification is just only at one point. It's not like covering whole the LVOT. So this is very important point, because this is always, it's going to introduce an error, and you will underestimate the aortic valve area if you are going to not exclude this calcification. The other source of error, it's the LVOT VTI. And this is very important to know how to measure it. So when you put the cursor, so we measure the LVOT VTI, as I mentioned before, that in the 5-chamber view or 3-chamber view. We try to put the cursor as far as possible in the LVOT, but before the acceleration in the flow. If you push this cursor too much to the aortic valve, you're gonna overestimate the aortic valve area, and you will start to have this kind of wave. Like you have a lot of kind of acceleration, flow acceleration, that indicate that you are not getting a good images for the LVOT VTI. This is a beautiful images, because you can see that this is a laminar flow without any significant acceleration. And the other also mistake that can occur, that if the echo technician, or if you acquire the images and you put the cursor too much toward the LV, then you will have an underestimation, because you're going to get a small LVOT VTI. This is the same patient, but we see here the small VTI because the cursor was too much toward the LV. So once you get a small LVOT VTI, then you will underestimate the aortic valve. So it's very important that you try to push the cursor as far as possible without inducing any acceleration, without showing any acceleration in the LVOT VTI. The last source of error, it's the aortic valve VTI. So for the aortic valve VTI, as I mentioned previously, that yes, go ahead. Is there anyone? Please, can you turn on?
Assalamu alaikum.
Wa alaikum salam.
I just joined the meeting, sorry. It's by mistake.
Yeah, no problem. Okay, no problem. So let's go back. So the other source of error, it will be the aortic valve VTI. So it's very important when you measure the aortic valve VTI that your echo beam should be parallel to the flow of the blood. So if it's not parallel to the flow, and if you are 20%, as I mentioned, more than 20% off, you will be significantly underestimate the velocity. One way to predict that, because as I mentioned previously, that when you measure the aortic valve VTI, you need to measure it from all the window and try to select the highest velocity. But one way to predict that the apical view will underestimate the VTI of the aortic valve is by calculating the angle, the ventricle to the aortic angle. If this less than 115, then you should know that you're gonna underestimate the aortic VTI if you measure it only from the apex. So you will need to do right parasternal view imaging and also suprasternal. So try to search the highest VTI. Like for example, this patient has a acute angle here we see, and from the apical view, the velocity was 3.7. But from the right parasternal, it's reached up all the way to 5.1. And actually, I just did a TEE for a patient with the bicuspid aortic valve. The apex was very low, like it was around 3 or something. And then when I did the TEE and I took different view, there was a significant, it was almost reaching 5. So it's always depend on the direction of the blood flow, and that the beam should always be parallel to this direction. Once you confirm that your reading is correct, so you will have a low aortic valve area with the low pressure gradient, then you have to calculate the flow index. So the flow index, it's basically we calculating the stroke volumes. The stroke volume is the LVOT area multiplied by the LVOT VTI, and then you divide it by the body surface area. If it's 35 milliliter or more, then you can say that maybe you have an error in the measurement, because you shouldn't have high stroke volume with the small aortic valve area and low pressure gradient. It does not make sense. There is some mistake that you need to go back and remeasure, or maybe you can do other modality to confirm your reading. But if you have a low stroke volume, less than 35, it means you are dealing with the low gradient aortic stenosis. Then you need to measure the ejection fraction. If it's 50 or more, then we say that this patient has paradoxical low flow, low gradient. Paradoxical low flow, low gradient, we usually see it in the patient, elderly patient above age of 70 years with a significant LVH. They will have this normal ejection fraction with the low flow and low gradient. But in the if your patient has a low ejection fraction, then we call this as classic low flow, low gradient. For the patient with the paradoxical low flow, low gradient, we usually do for them calcium score of the aortic valve. If it's 2,000 and more for male or 1,200 for female, then we say that the patient has significant aortic stenosis. However, if the patient has low flow, low gradient, the classic one, then you have to do low dose dobutamine stress echo. The low dose dobutamine stress echo is different than your regular dobutamine stress echo that usually you do for wall motion abnormality. Here we use a low dose. So we go all the way up to 20 mics, not like your regular dobutamine stress echo, which usually we go all the way to 40 mics. So here we will do the low dose. And if what's going to happen in these cases, either you're going to have flow reserve, which divide by increase in the stroke volume more than 20%, or you will have no flow reserve. So for the no flow reserve, you can do projected valve area. You can calculate the projected valve area. We'll show you how to calculate the projected valve area, or you can do the calcium score for the aortic valve. To see if the patient has significant aortic stenosis. Usually those has poor clinical outcome. But on the other hand, for the patient with the flow reserve, when the stroke volume increased by more than 20%, you're going to decide if the patient has true severe aortic stenosis or pseudo based on the aortic valve and the gradient. So in the true severe aortic stenosis, the aortic valve area will stay the same, but the mean gradient, the pressure gradient, will increase. While in the pseudo aortic stenosis, the area will increase and the gradient will stay the same. This is how we calculate the projected valve area. So if you remember at the beginning, I show you how to calculate the slope. So here, why we need the slope. So for example, let's say that we started from here. At rest, the patient aortic valve area, it's 6, and the flow, it's around, let's say it's around 140. And then you start the dobutamine stress echo. You reach up to 0.8. So let's say that you reach up to 0.8, but the flow increase, but it's not increased significantly. You reach up to 180. So you have no flow reserve. So from this line, you can calculate the slope. And with the slope, having the slope, you can calculate what is the predicted or projected valve area if this patient has normal flow. Like we say that if this patient normal flow, this will be the projected. So what is, for us, what is normal flow? It's around 250. We consider this as a normal flow. So what you will do, you will calculate the slope. So you will say that for example, here, aortic valve area with the exercise minus aortic valve area at rest divided by the flow with the exercise minus the flow at rest. The flow rate we calculated here in this calculation by dividing the stroke volume by the ejection time. Ejection time, you get it from here, from the Doppler. The ejection time will start it from the beginning of the LVOT VTI to the end. So this is the ejection time. So if you divide it and then you get the flow rate, and then from the flow rate, you just plug in here in this equation, and then you will get the projected aortic valve area. So the slope multiplied by 250 minus the flow rate at rest, and you add it to the aortic valve area at rest, and then you will get what is the projected. If it's more than 1, then you will say that this patient has pseudo. If it's less than 1, then you will say that this patient has true aortic valve stenosis. This one, it's like the concept from here, it's advanced, but basically what I'm trying to say here that the afterload can affect significantly your outcome. And afterload represented by both, by the systolic artery blood pressure and the net pressure gradient. And to improve your outcome in your patient, you need to reduce the systolic blood pressure to normal range. And it's very important to know that if you have a patient with a very high systolic blood pressure, for example, coming with a high systolic pressure, the measurement of the aortic valve, it will not be correct and it will be inaccurate. So it's very important to control the blood pressure and then redo the echo to check the aortic valve accurately. This is the summary of the aortic valve, how to diagnose aortic valve stenosis. Very important to know this. Very important to memorize it also for your exam. So this is for the velocity, mild, moderate, severe, mean pressure gradient. Here the aortic valve area, and this the index aortic valve area divided by body surface area. This is important mainly in the patient with the small body surface area and also teenager, because these patients, they will have small aortic valve area, but when you divide it by their body surface area, you will see that they don't have significant aortic stenosis. But this cannot be applied in obese patient with body mass index more than 30. It will be inaccurate, to be honest. But it's really good in the patient with the small body surface area. And here the velocity ratio, which basically we divided the maximum velocity of the maximum velocity of the LVOT VTI, or LVOT, divided by the maximum velocity of the aortic valve. You can also use the VTI instead of velocity, so you can divide the LVOT VTI divided by aortic valve VTI. In the patient with this is also to remember, in the patient with the atrial fibrillation, when you calculate the pressure gradient, very important. Make sure that the heart rate between 65 to 85, and you have to average at least 5. So you have to calculate 5, and you divide it by 5, and that will give you the average. If you want to calculate the aortic valve area in the patient with the atrial fibrillation, the way we do, you have 2 options. Either you average the LVOT VTI and average the aortic valve VTI and calculate the aortic valve area, or you can just match the preceding interval. For example, I will say, for example, here, let's say I want to use this aortic valve area VTI, aortic valve VTI. So I will measure the interval between here all the way to here, the prior, which is the preceding interval, and I will look for any LVOT VTI has the same preceding interval. Let's say the duration between here all the way to here, it's matching this one. So I can use this with this, because at the end of the day, when you calculate the aortic valve area, you are taking the ratio. So you don't need to average when you take the ratio. But if you want to average, that will be also okay, but it will be time consuming. So by this, now we finished the aortic valve stenosis. We'll start with the mitral stenosis. Mitral stenosis, the commonest cause is, as you know, the rheumatic heart disease in the young individual, and degenerative calcified mitral stenosis in elderly. It's very important to differentiate between both with echo. And at the end, we have the congenital. These are two examples. This is the way that we usually diagnose patient with aortic mitral stenosis. So as I mentioned in the aortic stenosis, we always start by visualizing the valve. If there is no restriction in the valve it's normal. You don't need to go through all the steps of us measuring the valve area and the gradient and all this stuff. But if there is, you see there is by the valve morphology, from the valve morphology, that there is a restriction or thickness or calcification, then you will say that maybe there is a stenosis and we have to measure the area and the gradient. So here you will see two patients, one in the left side and one in the right side. The one in the right side is the patient, I think most of you know that this patient typical for rheumatic heart disease. So these patients with rheumatic heart disease, they have this, there's a commissure of fusion here, and you have this fish mouth appearance of the mitral valve opening. You have the hockey stick appearance, and the hockey stick appearance because the patient has normal movement of the mid and base of the mitral leaflet with restriction at the tip of the leaflet. And this is why, and this is the cause of this hockey stick appearance. Sometimes we will have also some thickening of the cords and papillary muscle secondary to the rheumatic. And it's very important to know and differentiate from the degenerative and calcified. The degenerative, the lesion, here the lesion will start from the tip and it will progress to the mid and then the base. But here it will be opposite. In the degenerative calcified aortic valve, mitral valve disease, the lesion will start from the base. So the patient first will develop mitral annulus calcification, and then the patient will start to progress, and the degeneration and calcification will start to progress to mid to base of the mitral leaflet, and then mid and all the way to the tips of the mitral valve. The reason it's important to differentiate between the two, because let's say that you have a patient with the mild mitral stenosis, rheumatic, and this patient is young. Of course, this patient you have to start in this patient on penicillin monthly. But on the other hand, if the patient has degenerative calcification, of course, we're not going to start on a patient on antibiotic. So let's say that you have significant restriction and you want to assess the mitral stenosis and severity of the mitral stenosis, then this is the way that we do it. First, the mitral valve area. The mitral valve area is the gold standard to assess the severity of the mitral stenosis. There are 4 ways to do this. You can do planimetry, which is the standard and the gold standard, and you can use the pressure half-time, continuity equation, and PISA. PISA can be used for both, to calculate the area of the valve and also calculate the severity of the regurgitation. So here, if you want to do the planimetry, you can do it by 2 ways. You can do it with 2D or 3D. 3D always better than 2D. But if you want to do it with 2D, that's okay, but it's very important to use explain. How do we use explain? You put the probe and you show the images of the parasternal view, and you click explain or biplane in the machine. And you put the line exactly at the tip of the mitral valve. And then you measure it from the short axis, from this view, from the other view. The reason behind that, if you don't do this, and you just basically put the short axis view and measure it, you might overestimate the mitral valve area. Like here, if you just go up toward the atrium, you're going to overestimate the mitral valve area. So it's very important to do the explain to make sure that you are at the tip exactly of the mitral valve. And these are the grade. This is the last recommendation. We used to say, or I will say the guideline used to say that mitral stenosis, the American echocardiographer guideline, they used to say that severe is less than 1 centimeter, and moderate less than 1.5, and more than 1.5 it's mild. But here now the guideline, it's updated now. Even the American Society of Echo, as well as the American College. So both, they say now that severe is less than 1.5 centimeter. And from 2.5 to 1.6, this is moderate, and more than 2.5, this is considered as mild. Usually the symptoms start when the patient mitral area starts to be less than 2.5. The patient will start to have symptoms. Patient above 2.5, usually they don't have symptoms. And this is how we do the 3D. 3D, we usually do it with the TEE. You can do it with the transthoracic, but we usually do it with the TEE. TEE will give you a very good images like this, the one that you see here. But very important to know. I saw some of cardiologists, they measure the mitral valve area from this view. They will just basically trace. But this is wrong. You should not trace this view, because this will underestimate the mitral valve area. It's very important to use the multiplanar images, which is this way to measure. So the difference, you just need, like in the machine, if you have the machine, you're gonna click QLab, and then you can exactly put the line at the tip of the mitral area during mid-diastole, and then measure the area. So this is the correct way to measure the area by 3D, not this way, and like not directly from the 3D volume. The pressure half time, the tip here that I want to mention, and this is very important, that sometime the curve of the pressure, pressure half time will be bimodal. But let me say, what is the pressure half time? What is pressure half time? It's basically the time that required for the pressure to become half of the maximum gradient. Let's say here, like here it didn't say what is the pressure at the maximum, but let's say here the maximum pressure gradient, it's let's say 10 millimeter mercury. So the time required for this pressure gradient to reach to 5, this will be the pressure half time. And to measure the pressure half time, you basically place the line on the curve. But it's very important that sometime the curve, it will be bimodal. If bimodal means we will have a steep line here at the beginning, and then you will have more slow reduce in the pressure gradient. So very important, if you have the bimodal, to measure this one, not this one. So the red one, it's the wrong. You should not put the your trace on the steep line. You have to put it in the mid line, because this will overestimate the mitral valve area for you. So it's very important to put it here, not to overestimate the mitral valve area. And the equation, we usually, what we do, we measure the pressure half time. Let's say here the pressure half time is 182 millisecond. So we divide 220 divided by 182, and then you will get the mitral valve area. The problem with the pressure half time, it will be affected if you have mitral regurg, if you have aortic regurg. It's also affected by the compliance of the LA, LV. So this is why we always prefer to use the gold standard is the planimetry. But this is good also to measure and to compare as a supportive. The third method is the continuity equation. Here, the continuity equation will do the same to what we did with the aortic valve area when we measured the aortic valve area. So we will calculate the stroke volume across the LVOT. So we'll calculate the LVOT area multiplied by the LVOT VTI, and then we will be dividing this with the mitral valve VTI. But it's very important to know that when we divide it by mitral valve VTI, it's very important to use the continuous wave, not the pulse wave. So you measure basically the continuous wave. I think I have a picture here. So you measure the continuous wave, like you trace it here, the wave of the mitral VTI, and then you will get here the mitral valve VTI, mean pressure gradient, peak gradient, velocity. So from this VTI, you can calculate, after you calculate the stroke volume, you divide it by this VTI, and then you will calculate the mitral valve area. But it's also, this will be affected if you have, for example, mitral aortic regurg. It will affect the result. Mitral regurg also, it will affect the result. If you have aortic regurg, you can use the RVOT instead of the LVOT. And this is an example. Let's say that here we measure the diameter here of the LVOT. It's 1.7. You divide it by 2, you get 0.85. You multiply it by 0.85. You multiply it by pi, which is 3.14, and then you multiply it by the LVOT VTI. And from that, you will get the stroke volume. Then you divide it by the VTI of the mitral valve, and then you will get the mitral valve area. Here, the PISA, I talked to you at the beginning about the concept of the PISA, that here the velocity will be equal on this shell, and here the velocity will be equal on this shell, but the velocity will increase the more the fluid will approaching the orifice. So in the way that we do it, from this concept, we use the continuity equation. So we know here the flow, it's equal this flow. So if we know that flow equal this flow, all what we need, we calculate the area of this hemisphere. As I mentioned, remember this is a 3D shape. It's a hemisphere. It's not like a 2D shape. So it's like this. So you calculate the curved surface area from here. And to be able to calculate the curve, you need to measure the radius. So you measure the radius, square it, and then multiply it by 2, multiply it by pi, and then you will multiply it by the velocity of the blood here and this surface. And then you divide it by the velocity across the orifice, and it will give you the area of the mitral valve area. And nobody uses this anymore, but I just explain it here because we're going to use it in the regurgitation to estimate the regurgitation. So it's really good if you understand it here. It will be much easier when we apply it to the regurg. So this is how we're going to do it. So basically, you're going to say that the flow in the hemisphere is equal to the flow across the mitral valve. You will multiply the area of the hemisphere. I told you how to do it. Measure the radius and square it, multiply it by 2, multiply it by pi. Will give you the area, multiply the velocity. The velocity, how do you get the velocity? Yeah, this is important. Always remember that when you want to measure the PISA, it's very important to change the Nyquist limit. So you need to shift the base of the Nyquist limit. And you change it based on the flow. So here the flow of the blood is going like this, and you want to check the PISA here. So you should actually shift the base of the Nyquist limit upward. And then you will have better, actually, even hemisphere. And then you will use the number in the top, because the number in the top will represent the velocity at the side of the hemisphere, at the surface of the hemisphere. So this is how we measure it. But like later on, you will see in the MR, because the MR, the direction of the MR jet, it's this way. Then we will push the base downward. And then we will use the number in the bottom, not in the one in the top. You will see that later on. And then you will, of course, divide all this by the velocity, not the VTI of the mitral valve, the velocity. And you will take the velocity from here. Very important, yes, I forgot this. Very important, when you do all the equation that we mentioned previously, make sure that you're using the same unit. So for example, here, the unit is meter per second, but here we calculated the area and the velocity here all by centimeter. So you have to convert this into centimeter per second, multiplied by 100, then you will get 193, which is the centimeter per second. This is another concept, not very important, but just to mention it, that sometimes you need to adjust for the shape of the leaflet. Sometimes the shape of the leaflet make your hemisphere not real hemisphere. It will be less than hemisphere. So basically, if you want to correct for it, you will calculate the angle here and divide it by 180, and then multiply it by the area of that sphere that you already calculated from here, from the radius and the pi and 2. This is an example. So you will see here that this pizza has been calculated by both way, the simple way without correction and with the correction. Correction always will be less than the regular way. After you finish step 1, we said that you have to calculate the mitral valve area. Once you calculate the mitral valve area, then you need to measure the gradient. The gradient, the problem with the gradient, it's considered as a supportive. It's not a diagnostic, because there are so many things can affect your gradient. For example, if the patient in high flow state, anemia, hyperthyroidism, all this stuff can increase your gradient. Also, there are some factors can reduce the gradient. So sometimes you will have a patient with the severe mitral stenosis, and the gradient will be low. And the reason behind that, for example, if the patient has an ASD, or if the patient has post balloon valvuloplasty, because during balloon valvuloplasty, you will gonna create an ASD, and the flow of the blood gonna be toward both the mitral valve and this ASD, and that will reduce the gradient across the mitral valve. So this is why we always use it only as a supportive. And when you measure it, make sure that the heart rate between 60 and 80. If it's more than 80, the heart rate, you're gonna always, like the gradient will be overestimated for the mitral valve. And these are, again, the criteria to diagnose patient with, and to assess the patient with the mitral valve stenosis. It's very, very important to memorize it, this criteria for the exam. The third step, we said you measure the mitral valve area, you measure the mean pressure gradient across the mitral valve, and then you have to also to assess the pulmonary pressure. The way that we assess the pulmonary pressure by using the simplified Bernoulli equation, which is you will measure the tricuspid regurgitation, the TR velocity, and you square it, multiply it by 4, you get the gradient. This is the gradient across the, like in the TR. And then you will add the RA pressure to it. And then you will get the RV systolic pressure. So the RA pressure we estimated based on the size of the IVC and the collapsibility. So for example, here we'll say that if the size it's 1.2 or less, and it's collapsible more than 50%, we say that the gradient is in the RA, it's 3. If it's dilated and non-collapsible, we'll say the gradient is 15. Anything between, we're gonna say 8. And we add it to the TR. Like here, we can see that after you trace it, you can calculate the TR. No, this is the, I'm sorry, this is the mean. But if you want to calculate here the maximum, it will be something like almost 3. So you square it, multiply it by 4, and then you add, here you will see that the size is less than 2.1 and collapsible. So we'll say the RA gradient, it's the RA pressure, it's 3. So you will add the 3 to the gradient that you will be calculating from the TR velocity. This is again very important to memorize, to know the severity based on all these 4 criteria. The last things to do, it's also need to assess the size of the LA, because also this is a supporting factor for the severe MS. But remember, it's better to always use the volume. So it's very important to use the volume. You average the volume from the 4-chamber view and 2-chamber view and divide it by body surface area. And based on that, you can tell if the patient has mild, less than 34, or mild, moderate, or severe. In the patient with the MS, sometimes we do a stress echo, like aortic stenosis, but here we do it mainly if the patient, for example, symptomatic, but the stenosis is not significant. Like the patient is symptomatic with the exertion, but when we do echo at rest, we don't see significant mitral stenosis. Then we do the butamine stress echo. If the mean pressure gradient goes up more than 15 during exercise or more than 18 during dobutamine, you can do dobutamine or exercise. If it's more than 18, then you will say that this is a significant, and that will be an indication for balloon valvuloplasty. Also, if there is any significant increase in the pulmonary systolic pressure, that will be also another reason to say that this is symptoms related to the MS. Atrial fibrillation will say the same, that it's recommended that you average 5 in the patient with atrial fibrillation. However, here, if you want to do the continuity equation to measure the mitral valve area, you need to select an LVOT with the preceding interval that is matching the mitral valve VTI. So let's say that this interval from here to here, it's matching from here to here. So I'm gonna use this LVOT VTI, and I will use this mitral VTI to calculate the mitral valve area. One more thing here, Wilkins score. This is the mitral valve score. This score, we use it to see if the patient is eligible for balloon valvuloplasty based on the mobility of the valve, the thickening of the valve, calcification, and subvalvular thickening. If the patient has less than 8 score, we'll say that this is most likely going to be a successful procedure. If it's more than that, will be the patient going to be at high risk to fail or develop maybe even sometimes mitral valve regurgitation. I don't know if they can ask you in the exam about this, but it's good to read it and to know it. But remember that the cutoff is 8 to say that patient is going to be a good candidate or not a good candidate for balloon valvuloplasty. And rheumatic, of course, and rheumatic, not in the degenerative calcified mitral stenosis. I don't know if you want to take a 5-minute break or do you want us to continue? Now, like we finished with the aortic stenosis and mitral stenosis. Now we will have, after that, mitral regurg and then aortic regurg. Do you want to take a 5-minute break? Hello?
Yes, doctor. I think it's better to take 5 minutes, then we'll.
During this 5 minutes, if anyone have a question, you can ask now. If you have any question about what we discussed previously, anything not clear, you want me to explain again, let me know. Anyone have any question? Okay. Okay, we'll start after 5 minutes, the second part. Okay, we're gonna start the second part. Hopefully, the second part will be less condensed and less than the first part. So in the second part, we'll cover both mitral regurgitation and aortic regurgitation. And the good news that most of what we're gonna say in the mitral regurgitation, we can also apply it to the aortic regurgitation. So it will be, inshallah, easy topic. So whenever you have a patient with mitral regurgitation, it's very important from the echo to determine the cause and pathology. Is it primary, secondary, and what is the cause, underlying cause of the MR? Because that will significantly affect the way you're going to manage this mitral regurgitation. Also, you need to estimate the severity. So we're going to go quickly on both. For in terms of the causes, the primary one is which is one of the common causes, the mitral valve prolapse is one of the common cause of the mitral valve regurgitation. Rheumatic heart disease, of course, infective endocarditis, valve tumor, trauma, also degeneration, secondary to calcification. And it could be also secondary, like ischemic cardiomyopathy, non-ischemic cardiomyopathy, hypertrophic cardiomyopathy. All these can lead to what's called MR. We have a classification using Carpenter classification. We have type 1, 2, and 3. Type 1, they have a normal leaflet motion. But their problem either problem in the annulus, like annular dilatation, and we see that in the patient with the atrial fibrillation. Those patients with atrial fibrillation, idiopathic atrial fibrillation, they will start to develop enlargement of the left atrium. Their left atrium, it will become large, and then it will also pull the annulus, and that will lead to mitral regurgitation. It can be secondary to perforation. It's also this considered as type 1, because the leaflet motion of the leaflets will be normal, but the problem that we have perforation in the usually secondary to infective endocarditis or something like that. The type 2, they will have excessive movement of the leaflet, like prolapse, flail. We see it with the mitral valve prolapse. And then the type 3, which is divided into A and B. A, they will have thickening and fusion, which what we see in the rheumatic heart disease. They will have thickening and fusion and restriction in the leaflet itself. But type 3B, usually this is the secondary to non-ischemic cardiomyopathy or cardiomyopathy in general. They will have LV dilatation, and then that will cause tethering of the leaflets, and that will lead to the mitral regurgitation. Now the new approach to evaluate the mitral valve, it's this, using this criteria. So we have a specific criteria for severe mitral regurg, and we have a specific criteria for mild MR. So if you have 4 or more of these criteria, the one that's specific for severe mitral regurg, you can say this patient has severe mitral regurgitation, and you can stop here. You don't need to do the quantification. And if the patient has 4 or more of the mild MR criteria, then you can also say it's mild MR, and there is no need to do the quantitative method. But if the patient has criteria between 2 or 3 from here and there, then you have to do the quantification. So we're going to go through the criteria first, and then we're going to go through the quantification. So first, step 1, always image the valve and look for any pathology. And like, for example, this patient has a rupture of the cords, and that causing a severe mitral regurgitation. So look for any prolapse, flail, restriction, or tenting of the valve. Look for any thickening, calcification, vegetation, and also you can measure the annulus for any dilatation. And then also it's very important to evaluate the because let me mention that flail, it's considered as one of the specific criteria for severe mitral regurg. So if you have this, it's considered as a 1 point. And then you will assess the LV dilatation and the LV systolic function. If the patient has normal LV systolic function with the LV dilatation, that will consider another specific criteria for chronic MR. And then with the Doppler echo, it's very important to determine the site and the origin of the regurgitation and the direction of the jet. And when you state in the report the site of the MR, it's very important to mention in relation to the scallops. Like for example, here in the parasternal, you know that you have the A2 and B2, and from the short axis you have A1, 2, 3 anterior and B1, 2, 3 posterior. And for example, if the patient has MR here or the origin, you will say that the patient has MR between A1 and B1 or A2 and B2, like something like that. And from the 4-chamber view, you have B1, A2, A3. And from the 2-chamber view, it's almost like commercial view. You have B1, A2, and B3. And then once you localize the location of the jet and the direction, then you will do all these color Doppler component, which is all can be used as a criteria to determine if it's severe or mild MR. First, you will calculate the jet area to the LA area ratio. If it's more than 50%, this is considered as one of the criteria. You will measure the proximal flow conversion. And if it's 1 centimeter or more, that's considered also as a specific criteria. And then you will also measure the vena contracta. And if it's 7 millimeter or more, that's considered also as a specific criteria. But before you do that, it's very important to confirm that you have a correct settings in your machine. So very important, the Nyquist limit, when you evaluate the mitral regurg or the aortic regurg or any kind of regurg, very important, the Nyquist limit should be between 50 and 70. But if you have a low Nyquist limit, like here in this image, 17, you're gonna overestimate the regurg. So it's very important to put the correct Nyquist limit. You can see it here. So here it's 17, and here it's 15, 69. So it's very important to look for the Nyquist limit. The other thing, and this is really hard also, and it's really annoying, it's the color gain. So if the echo technician put a low color gain, you're gonna underestimate the jet, the regurgitation. So make sure that it's adjusted, and usually we tell them the color gain should be as high as possible without showing any noise in the non-moving object. So basically the echo technician should increase the color gain all the way before they start to see noise in the images. That should be the color gain that they should be adjusted. And here it's good. This one it's good because I don't see any significant noise in these images. So it's around 56, usually 50, 56, the color gain. Here, how to calculate the jet area to the LA area. You can do it from the 4-chamber, you can do it from the parasternal. 4-chamber will be a good way to do it, but very important when you trace the jet, not to include the dark color. The dark color indicate that this is a low flow velocity. So this is a low velocity blood, so you should not include it in your area of the jet. So you should just only measure the high velocity, which is the bright color that you see. And then you calculate the area of this jet and you divide it by the area of the left atrium. If it's more than 50%, we consider this is as a severe, one of the criteria for severe MR. But of course, you should know that this is not very reliable because it can be affected by your systolic blood pressure. If you have a high systolic blood pressure, of course, you're going to have significant jet area. So make sure that always when you even write the report for the echo to report the blood pressure. Here, the proximal flow conversion. We usually we use this for to calculate the PISA, to calculate the effective regurgitation orifice. But before you do that, you can measure just the radius here. And if it's 1 centimeter or more, you can say that this is one of the criteria of the severe. And if you have 4 or more criteria, then you don't need to do the quantitative. We use the PISA to calculate the quantitative and quantify the regurgitation volume and fraction, but we don't use it like here at the beginning. We use only the conversion, the radius itself. And this should be measured after you adjust the Nyquist limit to between 30 to 40. So you need to adjust. And as I told you previously, that when you want to adjust the Nyquist limit, you shift the base toward the jet. So this jet is going downward. So you need to shift the baseline downward. And when you use the number later on in the pizza, when you measure the pizza, you use this one, the bottom number, not the top number. Usually at the beginning, before you do the shift, it will be here. The baseline, it will be in the middle. But then you can control it from the machine itself. You can go up and down with the base, based on the jet. So here we also you need to measure the vena contracta. The vena contracta is the narrowest part of the jet. So you measure it. If it's 7 and more, that consider one criteria for MR. If it's less, consider as one criteria for mild MR. Also, you should check the flow reversal in the pulmonary veins. So normally, the patient should have S dominant. The flow should go from the pulmonary vein to the left atrium. So it will go upward because the flow is going upward. You should put the cursor, pulse wave cursor, inside the pulmonary vein. But if the patient has significant, severe MR, there will be a reversal. The flow will go from the left atrium into the pulmonary flow, and you will see a reversal in the S wave, because this is going to occur during the systole when the MR go back to the atrium. So that you will see this reversal. Another criteria, it's the mitral inflow. We always say that if the mitral inflow, the E velocity, more than 1.2, the European guidelines say 1.5, more than 1.5. Here we say American guidelines say 1.2, consider as significant MR. However, if you have an A dominant in the mitral inflow, you do this with the pulse wave across the mitral valve. If it's A dominant, this is considered as one of the mild MR criteria. Also, you can look to the density and contour of the mitral jet. So, for example, if it's faint like this, in this image, you can say this is one of the criteria of the mild. If it's dense, you cannot tell if it's moderate or severe. But however, if it's triangular, start to become triangular in shape, that indicates this is a severe mitral regurgitation. Also, you can do color and mode. The good thing about the color and mode, it's going to help you to see if it's hollow, systolic regurg, or late or early. So the late one, which is like this one, we see it in the mitral valve prolapse, and the early MR, we see it in the patient with the secondary MR, because those patients with the secondary MR, when they contract the ventricle will be dilated. So at the beginning, there will be malcoaptation in the leaflet and tether. But once some of this blood comes out of the ventricle, it becomes smaller, and the leaflet will start to co-opt. So then you will see that the regurg will stop at the end of the during the systole, like late systole. There will be no MR, late systole. So again, this is the criteria, as I mentioned. So you look for the specific criteria for severe, look for a specific criteria for mild, and if the patient has 4 or more of either, you will say this is severe or mild. But if it's not, you will start the quantitative method. The quantitative method, we have, we can use Doppler quantitative method, which using the same concept of continuity equation. We say that the blood flow during diastole across the mitral valve, which is across the mitral valve, it's equal to the blood flow during systole, which basically both the regurgitant volume as well as the LVOT stroke volume. So if you add the LVOT stroke volume to the regurgitant volume, you will get the mitral inflow stroke volume, the blood that's going to cross the mitral flow. So you will do the same, like the same way that we did with the aortic when we measured the aortic valve area. Here you will do the same. So first you will measure the LVOT diameter. From this diameter, you divide it by 2 to get the radius. You square it, multiply it by pi. You get the area of the LVOT. And we can do it actually here just as a practice and just to see how we do it. So let's say here it's 2. So if you divide it by 1, you get by 2, you get 1. So the radius is 1. You square it, you get 1 also. Then you multiply it by pi. So it's the end result will be the area of 3.45. 14. Then you will multiply it by the VTI of the LVOT. So we're gonna say multiply by 16 equal, so the LVOT stroke volume is 50 cc. And then we calculate a stroke volume that cross the mitral annulus. So you will measure the diameter of the mitral annulus. Let's say here it's 3. Again, you will do the same. You will say 3, this is the diameter. You want to divide it by 2 to get the radius. And then you square the radius by multiply it by the same number. And then you multiply it by pi. You get the area, and then you multiply it by the mitral valve VTI. This is a pulse wave. You use pulse wave, not the continuous wave. Be careful. Use here pulse wave. So you multiply it. You will say multiply by 19. Let's say here it's 19. So you get 134. So then you're gonna say, okay, now we know the stroke volume, crossing the mitral valve, and we know the crossing the mitral annulus, and we know the stroke volume crossing the LVOT. We do just subtraction. So we subtract. So we said 134 minus 50, because the LVOT is stroke volume 50. So we get 84. So it means the regurgitant volume, it's 84. And then if we want to calculate I will show you, but remember this number, 84. So we're gonna remember this. This is the regurgitant volume. Then we can divide it. I forgot, it was what? 120. I think it was, I don't remember, but it, like let's say this is divided, 84. Let me say 84. 84. 84. 50. So this was the number that we got when we calculate the volume across the mitral annulus. So we're gonna say 84 divided by this number to get the fraction, the regurgitant fraction. The regurgitant fraction, you divide it. The regurgitant volume divided by the mitral volume. So we got 84 divided by 24 divided by 134. You get 62. So this is the regurgitant fraction, 62. So we consider the patient has a severe mitral regurg if it's the volume more than 60 or more, or the regurgitant fraction 50 or more. So this patient match this criteria. So here again, so mitral valve stroke volume equal the mitral valve area multiplied by mitral valve VTI, and the LVOT the same. And then you will say that mitral valve stroke volume equal the regurgitant volume plus the LVOT stroke volume. One important point, and this is always happen when the ecotech get the images for us, the problem, they will take the pulse wave at the tip of the mitral valve. And if they take the pulse wave at the tip of the mitral valve, you can use it for diastolic function, to evaluate the diastolic function, but you cannot use it to quantify the stroke volume across the mitral annulus. If I always tell them that they have, if any patient with the mitral regurg, they have to give us a pulse wave at the level of the annulus. So they should put the cursor here, and we should use the pulse wave from here, not from here. Because if you use it from here, you will have a bigger VTI. So you're gonna overestimate the MR if you use the pulse wave from here. So you should always use it from here at the side of the annulus. The same way that we use here, like we always do the VTI from the annulus. Here it should be also from the annulus, not inside the left ventricle. And I show you how to calculate the regurgitant volume. Then you calculate the regurgitant fraction. At the end, you can also calculate the effective regurgitation orifice area. The way that we calculate the effective regurgitation orifice area, it means the area of the, you will say that maybe it's almost equivalent to the vena contracta area. So the area of the regurgitation. So the way we do it, we divided the regurgitation volume divided by the MR VTI. So the MR VTI. So we trace the MR VTI. For example, here we got 175. So what I'm gonna do, I will basically divide. I will say 84 divided by 175, and then I will get 0.48. So 0.48, this is centimeter square, the effective regurgitation. If I want to give it in millimeters, so I will say 48 millimeter square. So the advantage of using the Doppler, because now there is another way, I will show you how to use PISA to calculate the regurgitant volume and effective regurgitation orifice. But the good thing about using the Doppler to quantify the method, to quantify the regurgitation severity of the MR, the advantage, it's in some cases, you will see some cases with the late, the one that I showed you, with the late systole MR or sometimes early systole MR, those patients, if you look to the color only or the PISA, you're gonna overestimate the MR. Like for example, this patient. So this patient, when you see it like this, you're gonna overestimate. You will say, "Oh, this is significant," but this actually, it's not a holosystolic. It's only late systolic MR, and even you can do the if you check the regurgitation with the continuous Doppler, you will see that it's only half. So the systole starts from here all the way to here, but you see only half. There is a curve, only curve in here at the end. So it means there is MR only late systole, not early. So if you use, like for example, this case, when we do the PISA, the effective regurgitation orifice, it's almost moderate to severe. But when we use the volume, using the regurgitation orifice, it will be only 27 ml. So it will be very small. So this is the good thing about, but the limitation, of course, there is a limitation using a Doppler quantitative method, is the fact that if the patient have aortic regurg, you cannot use it if the patient has aortic regurg. And if the patient has MR and aortic regurg, you cannot use this method by using the LVOT. However, you can use it by using the RVOT. So by using RVOT, it means that instead of saying here LVOT, we'll change this and put the RVOT. So you're going to calculate the RVOT stroke volume, assuming that you don't have significant pulmonary regurg. So if you don't have pulmonary regurg, you can calculate the RVOT stroke volume from the RVOT area and the RVOT VTI, and then do the same equation, and you will get the same result. For the PISA, we're going to use the same way that we did for when we measured the mitral valve area. It's the same method, the same idea. You have a hemisphere here, and basically you're going to shift. First, your Nyquist limit shift it down because the jet is going down, and then you want to keep the number, the bottom number between 30 and 40, and then you measure the radius. From the radius, you calculate the surface area of this hemisphere, the curved surface area, and then you multiply it by the velocity, which the velocity, we know that the velocity here in this surface area, it's equal 33 centimeter per second. Of course, if you change the velocity here, you will see that, like for example, if you go less, you will see that the hemisphere will get bigger because you are including more lower velocity. So here it's lower velocity than 33 centimeter per second, and here higher velocity than 33. But here at the surface is at 33 centimeter per second. So basically, like here, we can do this also the same, just to show the equation how to do it. So let's say here, we say that here the radius is 1. So we're gonna say 1 square, 1, it's gonna be 1 also. And then you're gonna multiply it by 2, and then multiply it by pi. And that we're gonna give you the surface of the hemisphere. And then you're gonna multiply it by the velocity, because as I said, we are assuming that the flow here in this curve, it's equal to the flow here. So we're gonna multiply this by velocity. The velocity here 33 centimeters. So we're gonna say multiply by 33. And then you will divide it by the velocity, not VTI, by the velocity of the MR. So for example, here we have MR VTI, but the velocity, the maximum velocity, it's here. It's 543. Let's take this number. Let's say this number. So let's say 500, just to make it simple. Here there is differences. You can take the average, but let's say it's a 500. So we're gonna say divided by 500. So the effective regurgitation orifice, it's 4.41 centimeter square, or we can say 41 millimeter square. This is the regurgitation orifice. I mean, this is the orifice here. It's 0.44. And we know that 0.41, 0.40 and more, this is considered as a severe. The problem with this PISA method, it's like, for example, if the patient has, let's say, very eccentric jet, or if the patient has late systole, or as we said, it's not holosystolic, that will all affect, and it will not be accurate to use in these situations. One extra method that sometimes we use, especially when we use the TEE, which is the 3D vena contracta area. So we do a 3D at the site of the mitral regurg, and then we use the multiplanar, and we try to put it exactly at the narrowest part, and then we trace it. And from this trace, we can get exactly the vena contracta area, which is equivalent to the effective regurgitation orifice area. This is another one way. We do the 3D and then multiplanar, and then we measure the effective regurgitation orifice. I forgot to mention one thing. Here in the PISA, once you calculate the PISA, here we calculate the PISA as 0.41. Then if you want to calculate the regurgitant volume, you just multiply it by the MR VTI. So let's say here the MR VTI, it's 168. So you're gonna multiply it by 168, and you're gonna get the regurgitant volume. So the regurgitant volume here is 69. Okay. Here, the 3D also you can, from the 3D also you can calculate the what's called the vena contracta area, which is equivalent to effective regurgitation orifice area, and then multiply it also again by the MR VTI, and then you can get the same. You can get the regurgitant volume. The PISA and vena contracta, you cannot get from here what's called the regurgitant fraction. You can only get the regurgitant volume from the PISA and the vena contracta, 3D vena contracta. These other parameters that we always say that you have to do, the size and function of RV, LV, left atrium, right atrium size, concomitant valve disease if the patient has, and pulmonary pressure, as we mentioned before. You can do also stress echo for patient with the MR to unmask for patient with like if they are denying symptoms and you think that they are symptomatic because they are not active, you can do stress echo to see if the patient has symptoms. If there is an increase in effective regurgitation orifice with the stress echo to 13, like by 13 millimeter square, that will indicate that the patient has poor outcome, and also especially if there is an increase in the systolic pulmonary artery pressure to more than 60. This is the last part. It will be inshallah easy this because it will do the same like the one that we did in the MR. We'll do it here the same. So here also you will determine the cause, estimate the severity. These are the common causes. It can be congenital or acquired, including the bicasp, unicasp, quadricasp, VSD, connective tissue disease, like this is the cause of problem in the aorta root and cause the aortic regurg, or it could be acquired, calcification, endocarditis, rheumatic heart disease, all these causes. This is the classification that we use. Type 1, the problem we have, it's the leaflet itself, it's normal, but the problem is the aortic valve is dilated, but sometimes, like the movement, I mean, the motion of the leaflet is normal, but the only problem is dilatation, or it can be perforation. This is considered as type 1. Type 2, there is a prolapse, and type 3, it's restriction, like a patient with rheumatic heart disease. The mitral, the aortic regurg, it's the same as mitral regurg. We have criteria specific for severe aortic regurg, and there is a criteria specific for mild aortic regurg. If you have 4 or more, you can say that the patient has, for example, severe or mild without going to the quantitative method. Let's go quickly. So we'll do the same steps that we did with the mitral regurg. First, always image the valve, try to identify the cause of the problem. Like for example, here it's the root is dilated, so this is most likely the cause of the problem. Here it's prolapse, and there is some prolapse. Here some restriction, and this is most likely rheumatic or degeneration. I just want to mention here that the bicuspid aortic valve, the classification of the bicuspid, we used to use Seaver classification, which is basically it's divide the valve into true bicuspid, and there is a fusion between two cusp. But here the latest one, the international classification, it's classified into 3 group. The fused type, this patient has 3 aortic sinuses with 2 cusps, and the problem, they have a fusion in 2 of their cusps, causing raphe between this, and this is the most common cause of the bicuspid aortic valve. And if we say the most common one of them, it's a fusion between right and left cusp, and we have the 2 sinus bicuspid aortic valve, which is the true bicuspid aortic valve. These patients, they have 2 sinuses, only 2 sinuses, and they have only 2 cusps, and we divide them to lateral. I will show you, or anterior posterior. And the last group, it's the patient with the partial fusion. These are all examples. Like here is the fusion type. So we can see here there is a fusion between the left and right. Here fusion between right and non-coronary cusp, and here fusion between left and non-coronary cusp. It's very important to image the aortic valve in both during systole and diastole, because usually you will not see the bicuspid during diastole. You will only see it during systole. And here the true bicuspid, you will see here the type of anterior posterior, and here the lateral type. And then after you image the valve itself and determine the cause of the problem, then you will do a measuring. You see the LV function and the LV size, and from that you can tell if the patient has normal LV function with enlarged LV. That will be one of the criteria of severe chronic aortic regurg. It's very important, as we said with the mitral regurg, to determine the site and the origin of regurgitation based on the cusp. And to remember the location of the cusp, we always say that look for the septum. Regardless, you are doing transthoracic or TEE, look for the septum. Once you see the septum, you know that this is non-coronary cusp, the one beside the septum. And then the right, always beside the RVOT. Here the RVOT, here the RVOT. So the right coronary cusp always beside it. And the third one, it's always the left coronary. Here you can see even the left main coronary coming out of the left coronary cusp. Then you will see here the color Doppler. You will do color Doppler. You can do evaluate the jet width and divide it by LVOT diameter. If the ratio is 65% or more, then you will say that this is one of the criteria for severe. And if it's less than 25, you will say that this patient has a mild. And then you will look for the proximal flow conversion, the same what we did in the MR. And if it's large, then you will say this is one criteria for severe. And then also you will measure the vena contracta. If it's more than 6, you're going to say that this patient has severe, one of the criteria for severe. Again, here, this is how we calculate the ratio. So basically you calculate, you measure the diameter of the LVOT, and you measure the diameter of the jet. And if it's the ratio, you divide the ratio. Like let's say here, the ratio of the jet, it's the width of the jet is 0.8. And the LVOT is 2.4. So you divide it, 0.8 divided by 2.4, and then you get the percentage. So if it's more than 65 or more, this is severe. If it's less than that, it will consider as a mild. But the problem with this, you cannot apply it in the patient with the eccentric aortic regurg. So this patient is eccentric, so you cannot apply this. And this is one of the limitations. You can measure the vena contracta, and as I said, if it's more than 6, consider a criteria for severe. Less than 3, consider as criteria for mild. And also you measure the flow conversion, and based on the size, you can tell if it's consider as a criteria based on the size. And also you need to do the shift. Here, the shift will go down because we are doing that from the parasternal view, and the direction of the flow, it's going backward. So for the flow conversion, actually you can, for this one, like this one, usually the vena contracta and this jet, we usually do it from the parasternal, but for the flow conversion, we can do it from the parasternal, and also you can do it from 3-chamber and 4-chamber view. Very important to look for the flow reversal in the descending aorta. You can do that from the abdominal aorta, which is more specific. You can see here the flow should be going upward like this. So it's going upward during systole, but then it's going backward during diastole. So that indicates that the patient has severe, what this is considered one of the criteria of severe aortic regurg. Also, you can check the descending aorta in the thoracic region from the suprasternal view. But remember that this can be affected by many things. And for example, the compliance of the aorta, like if you have stiff aorta, you will have some reversal. But to say it's significant, you need to measure the end diastolic velocity. If the end diastolic velocity 20 or more, that's considered as significant. Like here, it's 44 centimeter per second. So if the velocity 20 centimeter per second or more, then you consider it as significant. Also, you can look to the density and regurgitation of the regurgitation jet. If it's faint like this, you can say this is one criteria for mild. If it's dense, you can say this could be moderate, could be severe. You cannot tell based on this jet. Then you will also measure the pressure half time. As I mentioned, pressure half time, it's the time that required for the pressure to go decrease by half. So if it's the pressure half time of more, like 500 or more, this is considered as mild. If it's less than 200, consider as a severe, one of the criteria for severe aortic regurg. But you need to remember that there are a lot of limitations with this, especially if there is increase in the LV diastolic pressure. That will give you a short pressure half time. So you cannot rely only in one criteria. Always try to use more than one criteria. And this is what the new guideline trying to say, that you can use more than one. If the patient has 4 criteria of definitive, then you can say that's severe. If it's less, then you have to quantify to make sure that. But it's still here, like if you see the criteria, there's also they say it's always better to quantify. But it depends also on how many patients you have that you need to read and how many echo that you need to report. But if it's clear from the beginning, based on the criteria, you can say that this is clearly severe, and you can always estimate. And for the estimation, we can do the same. Use Doppler quantitative method or using the PISA for the Doppler. Here we say that during diastole, we have 2 flow through the mitral valve and flow through the aortic valve. So if you add these, it will be the same as the flow during the systole. I'm assuming that you don't have MR. So this quantitative method using Doppler, you can apply it if you don't have MR. But if you have MR, you cannot use it because you cannot do the way that we did the subtract. So if you assume, like let's assume that we don't have MR, then you will do the same to what we did with the MR when we evaluate the MR. So you will calculate the stroke volume across the MR, the mitral annulus. Again, you calculate the area of the annulus, multiplied by the VTI, you get the stroke volume across the mitral annulus, and then also calculate the LVOT stroke volume by calculating the area multiplied by the VTI. And then you will say that LVOT stroke volume equal the regurgitant volume plus mitral valve stroke volume. And then if you do subtract, then you will get the regurgitant volume. You will say LVOT stroke volume will be, because it will be larger than the mitral valve stroke volume. You will do the subtract, you will get the regurgitant volume. You will divide it on the LVOT stroke volume, you will get the regurgitant fraction. And then if you divide it by the VTI of the aortic regurg, you will get the effective regurgitation orifice. The advantage and limitation, it's similar to the Doppler quantitative method that we used with the mitral regurg. Just to show you, like I want how to do it, because we have time to do it quickly. So let's say that first we're going to quantify this mitral annulus stroke volume. So we're going to say we have here the diameter 2.8, and then I will divide it by 2 to get the radius, and then I'm going to square it, so multiply it by itself, and then I'm going to multiply it by the pi 3.14. This will give me the area, and then I will multiply the area by the mitral valve VTI. As I told you, the mitral VTI, the pulse wave should be done at the level of the annulus. So let's say it's 9 here. So we'll say 9. So we get 55. And then here we'll do it the same for the LVOT. So LVOT here, let's say that it's 2.5 divided by 2. You get 1.25. You square it, multiply by itself. Then multiply by pi 3.14, you get the area, and then you multiply it by the VTI 25, you get 122. And then you do a subtract. Let's say I think we got what, 55? So it's going to be 67. So this is the regurgitant volume, 67. And if you divide it by 122, which is the LVOT stroke, you will get the regurgitant fraction, which is 55%. And if you want to calculate the effective regurgitation orifice, we said 67. We said the volume. So here the VTI, it's 152. So I will say 67, the regurgitant volume divided by the aortic regurg VTI. It's going to be 152. It will equal 0.44. So it's 0.44 centimeter square. This is the effective regurgitation orifice. You can multiply it by 100 to get the millimeter. You can say this is 44 millimeter square. Also, you can report it as a millimeter, or you can report it as a centimeter. If the patient, let's say that, yes, this is the first way actually to use the mitral stroke volume. But also you can use, and a lot of people, they use actually the RVOT. Instead of mitral, they use the RVOT. So you calculate the RVOT diameter from the short axis, and again, divide it by 2 and multiply it by the VTI of the pulmonary. And then you calculate the RV stroke volume, you calculate the LVOT stroke volume, and you're going to say that the LVOT stroke volume equal the regurgitant volume plus the RVOT stroke volume. And you will do the same. You will subtract and then divide by the LVOT stroke volume to get the regurgitant fraction, and if you divide it by the VTI, you will get the effective regurgitant orifice. Remember, we are here dividing by VTI, not by the maximum velocity. We're dividing by VTI. The maximum velocity, we're going to use it when we do the PISA. So for the PISA, as I mentioned, you can use it from parasternal, or you can use it from 5-chamber or 3-chamber. Look for the best PISA that you can get, and then you can use it. And you can do the same here. Let's do it quickly if you want to do it here. So we're going to say here the radius is 0.8. So I'm going to say 0.8, square it. It means I'm going to multiply it by, I'm sorry. Let's say 0.8, and then I'm going to square it. We'll say 0.8, multiply it by 0.8. Then I'm going to multiply it by pi, 3.4. Then I'm going to multiply it by 2. Because we are trying to find the curved surface area of the hemisphere. So it's going to be 4. And then I'm going to multiply by the velocity, which is 35 centimeter. 35 centimeter. Because if you see here, it's actually dot 35. But dot 35, they mean in meter, unit in meter. So as I told you, make sure that you're using the same unit. So we need it in centimeters. So I'm going to say 35. I'm going to multiply by 35. So it's going to be 140. Once we get the 140, then I will divide it by the maximum velocity across the regurgitation orifice to get the effective regurgitation orifice. So here the maximum velocity it's 350. So I'm gonna divide it by 350. I will get 0.4. This will say that the patient has a significant, because I will mention this later on, but because in the patient with aortic regurg, we consider severe if it's 0.3 and more, but in the mitral regurg, it's 0.4 and more. And maybe I will mention this is interesting things to mention later on. So this is basically how to do the PISA. PISA has a limitation, the same limitation that we mentioned in the mitral regurg. We can say that it's the same. Last thing, you can also do the 3D color Doppler vena contracta, the same way that we did with the mitral regurg. You can calculate it, and then when you calculate it, it's give you the same effective, almost like effective regurgitation orifice. But when you calculate it, always try to exclude the low velocity. So only try to trace the high velocity color, and measure all these stuff. One more thing I want to say, that you will see that in the mitral regurg, these numbers are important to remember, of course, and for your exam, so you make sure to remember. But I would say that it's interesting to say that the regurgitant volume, to say it's severe in the aortic valve and mitral regurg, aortic regurg and mitral regurg, it's 60 ml, the same. And for the regurgitant fraction, it's 50%, both. But the effective regurgitation orifice, you will see that we consider it severe for the aortic regurg if it's 0.3 or more. On the other hand, in the mitral regurg, we say it's 0.4 or more. Do you know why? Because I'm gonna finish with this question. Do you know why? Why do we say that 0.3 for the aortic regurg to say it's significant, and we say 0.4 for the mitral regurg? The reason behind that, it's the duration of the systole and the diastole. So the duration, although the duration of the systole is short, this is why we use a bigger, because for 60 ml, let's say this is the significant 60 ml, and regurgitant fraction is 50%. For the 60 ml to be moved from the left ventricle to the left atrium, for example, if in the MR, you need 0.4 orifice, because this is gonna cross during the systole, and the systole, the duration of systole is shorter than the duration of diastole. But on the diastole, you have longer duration, so you don't need a bigger effective regurgitant orifice area. 0.3, it's enough to move 30 cc from the aorta to the ventricle. So this is why, and this is why we always say, be careful, like patient, when you slow the heart rate of the patient of the aortic with the aortic regurg, you're gonna worsening the aortic regurg. The aortic regurg will get worse because there will be more volume gonna cross during the diastole. Any question? Do you have any question?
Just I have one question. The mitral valve stroke volume. So there is two ways to calculate. Either.
Yeah.
Okay. Thank you.
Oh, I'm sorry, I didn't get the question. So you mean you're asking about the way to calculate the mitral stroke volume?
Either by mitral valve area multiplied by mitral valve PTI, or by regurgitant volume plus LVOT stroke volume.
Okay, the good question. So the way that we usually use to calculate the mitral stroke volume, which is basically the blood that flow across the mitral annulus. We usually use the mitral annulus. We don't like to use the area itself. So always make sure that when you want to measure the mitral stroke volume, which is the blood that cross across during the mitral, and let me just open the images, just show you here. So let's say here, so make sure you measure the annulus, because we are measuring the flow of the volume across the annulus, mitral annulus. So you're gonna measure the annulus, you measure from the diameter, you're gonna calculate the area, and then you multiply it by the VTI at the site of the annulus. So you have to measure the pulse wave at the site of the annulus. And when you multiply it by each other, you're going to calculate the stroke volume. So you cannot use the continuous wave or pulse wave at the tip of the leaflet. No, you have to use the pulse wave here. So you will be able to calculate the stroke volume across this. And once you calculate the stroke volume, then you can do the subtraction to get the regurgitant volume.
Okay, thank you. It's clear.
Any other question? Is there any question? More question? No, here. Here I have a question. Mitral valve stroke volume have two.
أنا نفس سؤالي.
Oh, this is your question. Oh, okay. خلاص. Any other question ولا خلاص؟ Okay. Good luck. And if you have any question, you can always send it to Ibrahim. Ibrahim, he has my contact, and he can send it to me if you have any question.
شكرا دكتور.
يلا good luck. مع السلامة.